Hi, this is Dr. Alyssa Gaul. Thanks for joining me on this special webinar on coronavirus. Keep up to date on other webinars and events at whole-life-medicine.com. And so welcome to the second coronavirus update, which is about immunity and moving forward. Of course, we are still in the pandemic at present, and it continues to create a somewhat held back version of life. So we've already had the opportunity to discuss this virus and the basics in our first webinar. And I'm really going to try not to repeat too much of that, but instead, let's take a look at questions surrounding immunity and how we might see ourselves emerging from this a bit. We're going to cover also a couple of ideas that perhaps you haven't heard about before, because as you know, I'm horribly attached to journal articles. And so I read way too many journal articles. And of course, there's been a lot of interest for me in just seeing what kind of pieces of work are being done as we're going through this situation worldwide. So let's, why don't we're going to start by recapping here a little bit what we've already discussed. So if you missed coronavirus update number 1, you missed a bunch of like the basic stuff. So to recap, we've basically already discussed what this virus looks like, how it infects people. You'll remember it was the spike protein of SARS-CoV-2 binding to ACE2, which is the transmembrane enzyme that's found in lungs and arteries and heart and kidneys and intestines. We also talked about how common coronaviruses are, and that, basically coronaviruses are responsible for multiple different common cold type infections in human beings, and they're also found in animals. And in this case, SARS-CoV-2 virus shares genetic traits with coronaviruses that infect bats and pangolins, which seriously is one of the most cute little animals on the planet, the pangolin. Who doesn't want one of those? And also how this particular virus is a more infectious variant of the usual virus. We talked about who was most likely at risk. And we're going to expand on that a little today. We also looked at relative risk of dying from various causes and where this virus is likely going to land in terms of statistics. And today we can kind of extend through these to some extent. We also talked about common sense measures and the most likely useful nutritional, homeopathic, and herbal prevention. And we talked about fever and how to appropriately work with it to maximize its healing effect. That was really brought home to me this week when I was reading through one of my journal services, and there was a kind of a biography done by a physician, and he was a cardiologist. Granted, it was not a family physician or infectious disease expert, but he got COVID, and so he was stuck at home in his room. He was like isolated in his room with his family kind of outside the door, feeding him things through the door. And what was really interesting is how clear it was that he had absolutely no clue how to appropriately deal with an acute illness. He wasn't resting properly. He was eating during a fever. All the things I tell you not to do, he was basically doing. Granted, he lived. It was all good. He had a mild, probably case. But it just brought back, if you want something to be efficient and you want to work through an infection properly, you want to take advantage of your immunity, you need to know those things. And hopefully all of you have heard me repeatedly talk about those concepts. And if you haven't, you can go back to coronavirus update 1, or if you really have no idea what I'm talking about, one of the best courses we ever did was acute illness in kids. Not because it's just about kids, but because I would possibly include spouses in that. But, there's so many basic and yet crucial and very effective ways of taking care of illness at home. And so, really brought it home to me this week that there's a lot of people who are medical professionals that still haven't learned some of those basics. We need to be reminded sometimes of those basics. So I will beat that drum repetitively through your entire relationship to me. Okay, so quick statistical review. Currently, we have several million cases across the world. This is actually the WHO regional statistics that should be accurate to about today. And you can see where the majority of the cases are focused. And the current death rate globally for all regions is about 6.9% based on reported cases. There is very strong suspicion, of course, that the full caseload numbers are not really being reported. There's multiple reasons for that. As a great example, with current trends, more than 5 billion people do not access essential services across the world. So the ability to see a healthcare worker or access essential medicine or even have running water in hospitals. And that estimate is continued to project through the next 10 years. So we are going to have reporting problems in various locations, as you can well imagine. And so we have to take those things into consideration. Now we can take a look here more specifically at Canada. So Canada has 69,156 as of 6:42 today. That's amazing to me that you can just get up to the minute data like that. And there have been 4,900 approximately deaths. That is a very similar death rate actually in comparison to the rest of the world. Most of those cases at present are in Quebec, unfortunately, and there's lots of cultural reasons for that. There are very strong connections between communities in Montreal specifically and to New York and to France. If you've never been to Montreal, there's very strong like Hasidic Jewish population there. In the region of Outremont. And so it's hypothesized that this is one of the reasons why that became such an outbreak center, was because of those connections. At present, in Alberta, it's looking substantially better than that. We've basically only lost about 1.8% of cases in Alberta, whereas it is the 7.9 in Quebec. No healthcare workers have died here. And you can see, this is up to today's data, you can see that most of the deaths here are in a population that's substantially older. Oh yes, Shireen is here. Shireen is a former Calgarian and is currently in Montreal. She could probably tell us all about the woes over there. I know that the healthcare system in Quebec is also organized a little bit differently, not in terms of essential care, but there's a great deal more physician-based care, especially in geriatrics in Montreal. I have one of my friends that practices in Montreal as a MD, is a geriatrician. So that's a specialist in older individuals, seniors. And I've heard her many times talking about the different approach that they basically take, and so they're very much more community based. And I think again that might have also partially been part of the problem in the beginning. But you're in our thoughts, Miss Shireen, and I'm sure it will all work out in the end. And if not, you can come hang out here for a little while till it passes. Now, I just wanted to show that because, like I said, at present, Alberta is not doing too badly, relatively speaking. And our case numbers are dropping, although you will notice on this graph that around Easter, which was the 12th of April, we saw a big spike after Easter. Because I think we just all went to each other's houses. That's my interpretation. And you saw about like 5 days later that all of a sudden the case spike went up. And then now it's coming back down again because we don't have an Easter. Granted, we do have the Victoria Day long weekend coming up. And even though it's not as big of a holiday, It wouldn't surprise me if there isn't a little blip and that we kind of see that kind of moving forward as well. So, take homes from this, though, are that we're doing fairly well in terms of case count. Our active case numbers are coming down, and we have a very specific set of at-risk people here. So let's talk about that a little bit. So we've already talked about this to some extent. Clearly the evidence is there that there's comorbidities creating more vulnerable people. So hypertension, which is high blood pressure, diabetes, respiratory diseases like chronic obstructive pulmonary disease, to a degree asthma, and other cardiovascular diseases are increasing the risk of severe disease, meaning an infection that could create some very significant illness symptoms and potentially death. Obviously, increased age is a clear risk factor. This is, like we've talked about before, also very likely in flu and other viral infections that come in waves. And interestingly, there's a couple of other things that are showing up in the literature that might be correlated to vulnerability. One is that blood type A seems to be more vulnerable. This was based on some data that was done by the Southern University of Science and Technology in China. And what they did, this is not yet a peer-reviewed study, this is a preprint study that compared distribution of blood types amongst about 2,100 COVID-19 patients in 3 hospitals in Wuhan. And they compared them with uninfected people in the same areas. And blood type A appeared to be associated with a higher risk of contracting the virus, whereas type O offers the most protection for reasons that have yet to be determined. And there was some kind of like conjecture about why that might be the case, but it's very interesting that has shown up. The second thing that has shown up is that there's a subtype of ACE1 receptor, and you'll remember that we talked about the ACE1 receptors being one of the binding site, the binding site for coronavirus. That there's one of several genetic variants of this transmembrane enzyme that's associated with kind of low levels of expression of the ACE2 gene. And so as a result, those cells in those people contain fewer of those receptors that allow infection. And so the frequency of the ACE1D gene differs from one country to another, especially in Europe. So that's raising the question of whether some of the geographical distribution of this variant is correlating with COVID-19 prevalence. There's also a set of human leukocyte antigen genes. So these are genes that people might have heard of because they can form some of the risk factors for immune diseases or autoimmune diseases. And there's a couple of variants of HLB that can increase susceptibility, and then there's ones that can decrease it. So again, we're seeing that there's variations in the immune system that are potentially creating more or less risk. And the supposition or conclusions from that are that if we know those pieces, if we know what the genetic background of the person is, or we can do these specific gene tests, we can actually determine the appropriateness of certain kinds of preventative measures. Like as an example, if there was a relevant vaccine, that there might be populations that are just going to be better suited to that kind of intervention. We're going to talk about vaccines, of course, in this lecture, because I'm sure everybody has some questions about that. And also, typically a vulnerable population for lots of things tends to be our younger cohort, but in this case, incidence under age 15 is really low. It's estimated at under 1%, and the symptoms are typically quite a bit more mild. That doesn't mean that there aren't some severe cases and that we haven't had some losses in that age frame, but it's really not the highest and most vulnerable population by any stretch. And there may be some very interesting reasons for that, to do with T-cell immunity and the fact that in children you see more thymus activity. The thymus is a gland behind your sternum that tends to involute as you get older. Doesn't mean you don't have cells that come from that part of the immune system, but it might be one theory as to why we see kids not really having as much trouble with this. Don't quote me though, because I have not done a study on that. No, one of the other things I did want to point out, because I have not heard about this much in Canada, but this is probably because Canada is not collecting this kind of data. But there are clear differences amongst different ethnic groups in vulnerability. Canada has stated publicly it's not going to be collecting this data. I am not entirely sure why. But in the UK, this kind of came up quite clearly, and the first 11 doctors in that country to die of COVID were of ethnic minority. And even though the testing data, so the amount of testing that they were doing was showing that the distribution of cases seemed to be pretty close to the country's like normal composition, severe cases were not. So basically, 13% of the UK population is considered an ethnic minority, but 33% of the severe cases were people of ethnic minority. And we're seeing this also show up in the United States. So African Americans are at a 33% rate of hospitalization, even though their population number is only 18%. And death rates are substantially higher for African Americans, for Hispanic Americans. White was kind of on the low end, so Caucasian people, and then Asian was a little bit lower. So that might be partially to do with gene bases. We're not 100% sure about that. But it is interesting that we're starting to see that data coming back from countries that are bothering to measure it. And I don't know what it's like here. Because there's not enough cases probably to really kind of get a sense of who's suffering from it the most, at least in this province. I continue not to have any COVID-19 cases in my practice, which is good. I'm hoping that means you all are taking care of yourselves. But then I don't get to observe up close and personal. But I think this is an important piece to bring in because it also reflects, again, probably socioeconomic circumstances. And I think that anytime we talk about healthcare, we do have to remain cognizant of that. Disease weirdness. I just wanted to talk a little bit about disease weirdness because there is just some really interesting stuff about this this infection that's so unusual. So we're seeing some interesting weirdness. Like we were talked about before, this is a bilateral viral pneumonia. That means both lungs are getting infected and creating very severe respiratory distress in the bad cases. But what's really interesting is that there's some peculiarities about it that have been observed, like that sometimes significantly ill people with a super low oxygen saturation. So, in the office, when I put the monitor on your finger and I'm checking to see how much oxygen you have, what I'm looking for is I'm looking to see, are you having trouble breathing and actually getting oxygen in? But it's a very interesting mechanism that's allowing a low oxygen saturation, like low to the point where you'd think somebody be quite sleepy and not really able to be talking to you. Being perfectly fine. And there seems to be some very interesting blood dynamics behind that. And so we're going to talk about that a little bit momentarily. The other thing is that this particular kind of viral pneumonia is not responding to the normal measures for viral pneumonia, like that you would see, say, in influenza. And this was a cause of some of the original problems with mechanical ventilation, is that typically people with viral pneumonia would be able to stand mechanical ventilation, earlier in the process. But what has been found with COVID-19 is that if you try to do that, sometimes it actually puts people into more distress more quickly, and then it's actually best reserved for later in the game. And it seems to have to do with just the clinical course. But what's also interesting is nobody really is knowing why this virus is having such a dramatic effect, really. I mean, there's some observations, obviously, about the fact that there's a certain kind of damage at the lung tissue level. There's not a ton of understanding as to how this is really truly different from another viral pneumonia at a molecular level. And so there's some struggle right now to try and figure out what that is. But of course, what that means is that figuring out how to treat it has been exceptionally challenging. And at this point, we're going to talk about this a bit today, that there's been some real challenges from the perspective of like, what do you even try? Because some things have definitely been shown to be not particularly effective, and we're going to talk about some of those things today. There's also a very interesting thing that's happening. I'm sure you might have heard of the expression COVID toes. We're starting to see people who seem to have like a kind of purpura in the extremities. That's just where you are clearly getting some kind of like blood coagulation in the extremity. In fact, some people are showing up as almost looking like they have DIC-like symptomatology. DIC is disseminated intravascular coagulation. Interestingly, some people are having more blood clotting and some people are having less. And again, this seems to have some sort of relationship potentially to genetics. The lungs of patients with COVID also show this kind of microthromboses, so little tiny blood clots, big ones and small ones. And then obviously outside the lungs, like here in the toes, you're seeing these lesions. And there's children presenting with features that kind of look like Kawasaki disease. I don't know if any of you know what that is, but it's another kind of infectious disease that tends to be very cardiovascularly centered. And so circumstantially, it kind of seems related. So there's definitely endothelial damage. That means the inside linings of the blood vessels are being affected. And we talked about this already in Coronavirus Update 1, but it's starting to become more clear that that actually is a substantial part of this. And in very, very severe cases, there are definitely markers of coagulation showing up. So if somebody already has a clotting disorder, if they have a known clotting cascade problem, then there's possibly more risk in some of those patients. Now, the drug situation. There have been a couple of barks up drug trees with varying results. Unfortunately, no therapy has really been convincingly shown to boost survival in people with COVID-19 so far. At least not markedly. And there are no technically approved drugs directly for it. In the United States and Canada, there are laws that allow for the use of agents that are not approved for this condition on compassionate grounds, meaning somebody might have very severe disease and you're kind of running out of options. And so under those conditions, you're allowed to apply a drug that may not be approved for use in that particular condition. That is not unusual when there's severe disease. Like as an example, you can see that same approach taken if people have like rare forms of cancer or cancers that don't have a particularly effective treatment. You can sometimes just procure drugs on compassionate grounds. You'll see that also in autoimmune diseases. And so really we're in that situation right now because there have been some pretty like significant fails here. There was some attempts to use HIV drugs. They were trialed, really didn't show anything because HIV has some of the same immunological effects as coronavirus, this particular coronavirus seemed to. And so in theory, they thought that might help. That didn't really seem to do anything. Hydroxychloroquine hasn't had very strong evidence either. In fact, the trials were stopped early because the side effect profile was quite bad. And so that doesn't look like a great solution. I know that that was touted in the United States for a window of time, but that didn't end up looking very good. Also, there was some drugs affecting interleukin-6. Those are, there are a set of drugs that were used for already exist for the treatment of rheumatoid arthritis, so like autoimmune disorders. And so they tried to test it in China. That didn't really come out that well either. And at the end of the day, there is one drug called remdesivir. It's interfering with replication of some viruses, including the SARS-CoV-2. It's really had the best results so far. But basically, all it's managed to do is shorten the time from 15 days to 11-day recovery with a slightly reduced chance of death that actually technically was not statistically significant. So be that as it may, it might be a jumping off point for figuring out, okay, what is it about that particular antiviral that might be helping? But at present, really the data is just not there for any smashing drug. I'm not the first person to do that, but in this circumstance, there are going to be times where we really need to take a look at all your potential options, right? Now, there are some testing problems. And mostly, there's a couple of different kind of categories of testing problems. One is misunderstanding of testing. I think that's one of the bigger problems, especially amongst the public. I've noticed that the media does not necessarily do a particularly wonderful job of really truly explaining the details of what a test does and why, and what it is good for and why, and what it is not good for and why. And so I don't have very much patience for that, personally. And there are some tests. I know that there's some interest in antibody testing, which people have already asked me about. There aren't any approved antibody tests at present in Canada. There are some that are being evaluated. In the US, this is known as the rapid test. Now, of course, when we use the word rapid, somehow that makes it seem like better, but it's not. But it's not that it's not a useful test. It is useful in some circumstances, but it's interesting because I've seen a lot of arguments like, why aren't we doing the rapid testing here? We need to get on this rapid testing. Canada's actually manufacturing rapid tests and then shipping them to the United States. Why are we doing that? The US has really opened it up for lots of different laboratory testing, but that's it's a different climate. Like they have a differently organized system. And so whether or not a lab test is covered is up to an individual insurers for the vast majority of Americans, and then up to Medicare for the remaining. So in essence, it's not actually that rapid of a test, but it kind of is. So in essence, what a rapid test is an antibody test that tests for IgG and IgM. And so in infections, what we have is a kind of immediate type of antibody that shows up when you're first infected, and then a kind of antibody that tends to rise when you are starting to develop more competent immune reactions. So what the rapid test is doing is it's in 15 minutes or so testing a blood sample for the presence of those antibodies in your blood. Now, there are some problems with this interpretation, though. So what this test can really tell you rapidly, like in 15 minutes, is if somebody in front of you who's quite ill has COVID-19 or not. And that's actually probably the most appropriate use for it, not in screening people to see whether or not they're immune. And I want to talk to you a little bit about this today, because this is really important that we understand that. What we are predominantly using in Canada is PCR technology. That is where we take a sample and it's DNA amplification. That means that if you have a little bit of virus and we manage to catch it, and then we amplify the DNA, we can actually make the viral infection more obvious in the sample, not in you, but in the sample. And so it's a more sensitive test. So it is the diagnostic test for COVID. The other rapid test is not technically considered diagnostic in Canada or really anywhere else. The problem is that in order to get a proper swab to diagnose COVID-19, you need a pretty highly personal protective equipmented up technician, and they need to be pretty good at taking the swab sample. The swab samples the swabs are big. I don't know if you've ever had a nasopharyngeal swab, but I mean it's like a ginormous Q-tip. It kind of feels a little bit like people are going to poke your brain with it, because they're long. And they're meant to go in your nose and all the way back to the back of your pharynx, which really is like at the level of your ears. So it's a little bit disconcerting to have people stick a big Q-tip up your nose like that. And it takes a certain amount of talent to get the right sample. Now, why that's important is that when you are searching for virus, this particular virus infects people quickly and drops into the lungs quickly. So you need a pretty good sample to make sure that you're actually picking it up. And with a PCR, you can run hundreds of tests at a time. You can put it in a sequencer, in an analyzer, and literally run hundreds. The rapid test actually is a cartridge test, and I'll show you a picture of it in a minute. And so you can only run one at a time. And so there's some limitations to that. And like the weaker your sample, like the more likely you're going to get a false negative, really, with any kind of test. So, we need a certain kind of quality to the test to use it for diagnostic purposes. So this is what the rapid tests look like. It looks kind of like a pregnancy test, if you've ever taken one of these particular kind of pregnancy tests. Now, the question here is, are antibodies showing you immunity or not? And there's some interesting answers to this question. First of all, it's true that a strong antibody response will be seen in people who've been recovered recently. So you will see, and I'm going to show you a diagram shortly that shows, kind of like what the flow of which immunoglobulin comes up and when the viral DNA stops being produced. So I'm going to show you that in a sec. But in essence, not everybody produces these things in the same way. Some people don't produce antibodies until really late, like a month after infection. Well, if you're testing those people and they have the active infection and you're using rapid tests, you're going to miss them. And 20% of people, according to one study that I've just put the reference to down here at the bottom, had viral RNA 2 weeks after recuperation. And it was really unclear based on this particular technique that they used, whether or not it was active virus or not, or just destroyed viral particles. But regardless, there's still quite a bit of uncertainty about what all of these pieces of data mean. And I'm going to tell you a little bit more about that in just a second. There's also a distinct problem. It's totally possible and quite likely that there might be some fecal oral transmission going on. There's literature in China and Korea that was showing fecal shedding for 5 to 6 weeks potentially, and that you're seeing viral particles in stool before the nasopharyngeal swabs. So we've been very, very concentrated, obviously, on respiratory droplet transmission, which of course is totally appropriate, but there may be other reasons why we're seeing community spread. And we're probably just not going to go there, I think, just in terms of our own strategy in Alberta. I mean, who knows, maybe that will get expanded if we start to see this as potentially something recurring. But wash your hands, please, in the bathroom, especially at Costco. Goes without saying. Okay. So I want, actually, that's come up interestingly that, people are using fecal transplants now for chronic inflammatory bowel disease. I don't know if you've ever heard of that. I think we talked about it a little bit when we talked about gut diseases not too long ago. But of course, this is a concern because, if you are getting active coronavirus in somebody asymptomatic and you're doing a fecal transplant, you're basically could potentially be infecting somebody who's already immunocompromised. Not fun. Now, like I said, nobody really has any clue how long you could be immune for. And there's been no global surveillance on coronaviruses as a category because historically they just haven't been deadly enough. So we have like 6 months of data right now about this particular organism. And it's unfortunate because we're having to extrapolate a lot. And obviously, from a treatment perspective, that extrapolation has not been particularly successful. And I think we have to really look at some of the other data about this. So data on other coronaviruses, so ones that cause the common cold symptoms, they don't show full long-term immunity in the typical way. What we typically will see in immunity for lots of different kind of viral infectious diseases is we see antibodies long-term and B cells, which are kind of white blood cell that pump out antibodies reliably upon exposure, again, to the antigen within the normal immune mechanism. However, there are some serious challenges in this. So there was one study that was showing that there are not necessarily antibody positive rates in that same way that you would expect. And in fact, in one study, it was showing it was very low in the first 5 days after the initial onset of symptoms. And it didn't really increase until about 10 days later. And then after 10 days, the antibody positive rates jumped to like above 80% from less than 50 on the original tests. On the contrary, the positive rates of like having viral RNA kept above 60% in the first 11 days and then decreased. And so half the suspected patients with symptoms only were detected to be antibody positive. And there have been some longer term studies on original coronavirus survivors that are showing that they don't have antibodies after several years post this, and that they're not, so they don't have circulating antibodies at all. In fact, what they seem to have more of is T cells. So memory T cells. And remember, I was talking about the thymus earlier. This is a different part of the immune system creating memory. And it's a normal part of the immune system that creates memory, but it is not the classical one. So this is going to create some challenges for vaccines, probably. And of course, I'm not at the forefront of developing vaccines. Again, not always my favorite topic. However, there's going to be some really interesting differences in this infection that's probably going to pose a challenge. And this is one of the reasons too why we're not probably going to be able to use immunoglobulin rapid tests to show that people are immune, because of this longer term data that we have with other coronaviruses. It's basically saying this is probably not going to show the classic antibody increases that are extended over the long period of time. The supposition has, of course, all the way along this been that that's the case, but there is some data to the contrary, and we don't have enough data specific right now to COVID-19. Classic kind of diagram here, but here we're only talking about, a 21-day span on this graph with the day 10 kind of in the middle here. And we're seeing, some we're seeing the viral loads go up and then down, and then we're seeing the immune response afterwards. This has kind of been pretty typical for COVID-19. But like I said, unfortunately, it's not the same as every other infectious disease, and this is going to be an interesting problem long term. I think this may also be one of the reasons why we're seeing that the older people are really struggling with this, is that they don't have really great T cell activity. That could be part of the problem. So let's talk about vaccines here for a second. There are just an astonishing number of independent groups in active vaccine development right now. About 70 to 80% of the groups that are known are independent groups. That means they are not governmental in origin. So they're private companies attempting to find some sort of active vaccine. The WHO considers about 7 or 8 of those at the top of the pile. But really, realistically, vaccine trials are long. I'm just going to take a minute here. If you can't hear, refresh. There's a refresh button. Everybody else having that same problem? Refresh works. Okay, great. Yeah, sometimes depending on your internet connection, sometimes it will just cut out. So sorry about that. So again, like I said, there's over 100 groups really in active vaccine development, and there are all sorts of different approaches to it, because at this point, again, nobody has any clue if they can even produce an effective vaccine. Vaccine development is usually a very long process. The shortest it's going to be is if people are super familiar with the organism, like in the case of the flu. Obviously, they're producing a vaccine for the flu every year. It's, of course, not 100% vaccine. The efficacy is around 30%, but what they're trying to do is anticipate variations in the flu virus, and then try and actually mitigate that with a vaccine that's matching it better. Now here, we don't have any clue about this. And we have coronavirus vaccines in animals, but not really in humans, again, for this reason that they've never been particularly deadly. And then we also have the problem of coronaviruses not really showing long-term immunity. And so we don't even know if we can create a vaccine with long-term immunity. We can't even get a person to look long-term immune from the looks of it in a natural infection. But a vaccine trial takes a long time. A phase 1, there's usually 4 phases. The first phase is just actually introducing a potential vaccine into a small human population with a placebo, just to see, can you induce antibody production or not? And then to see if there's any side effects or any statistically significant effect and outcome at all. A phase 2 trial is more healthy volunteers in the vaccine target population. Again, our vaccine target populations for this are older people. And so that's probably not the best place to be testing vaccines. And you need hundreds of people, obviously, to determine reactions. Phase 3 is where you tend to go into toxicity and immunogenicity and side effect profiles on a much larger scale. You have to actually show that it's safe and effective in natural disease conditions. And we don't have that. We don't have a great window for that right now, unless this repeats again. Obviously, people can take the virus on purpose and infect people who volunteer to do this kind of work. And then phase 4 trials are usually monitoring usage and schedules and long-term immunity. And so usually that takes a good chunk of time to do that well, and to do it successfully, and to do it safely. So I don't know, maybe people are going to be trying to push a vaccine forward past all those safety protocols. A vaccine's probably likely a year away at minimum. There's one group at Oxford that's, I think, a little bit ahead of the group because they've been working on this problem prior to this, not this particular vaccine, but something similar. So maybe, but I'm not going to hold my breath on that. And again, we're talking about populations that, at-risk populations that are, not easily experimented upon, I should think. So, again, don't want to rule it out. There have been some trials at present for the BCG vaccine. That's a vaccine for TB that's being trialed. It has been found in some populations. This vaccine is used more in Africa in high tuberculosis populations. It's used here too. Don't get me wrong, it's used here too, but it's more used in other locations in the world. And it seems to have non-specific immune stimulating effects. And so there's 2 trials at present, I believe, that are looking for some effect in coronavirus. We won't know if that's the case. The WHO is definitely not waiting on that. Okay. So some more take-home messages. I think personally immune strength is key. Good rest, stay hydrated, stay active, don't panic. I am sticking by most of my original therapy thoughts in coronavirus update 1. If you missed that, you can go back and take a look at the replay. It's on whole-life-medicine.com. I do have colleagues in more infected areas reporting usefulness from ligusticum, that's OSHA root. If you've ever had ever been cornered in the dispensary by myself to sniff my favorite herb, this is actually my favorite sniffing herb because it smells so wonderful. It doesn't taste so as good as it smells, but it is a really good respiratory antiviral. And it's actually in our immune formula, the glycerate for kids, and also big people. Just we don't have to usually use the sweetener for the big people. Mushrooms, and obviously we're going to do this webinar again next week for mushrooms. If you missed it the first time, it was because I actually had a bit of a snafu with the webinar system, and it didn't record, which is a bummer because it's always my funniest webinars that don't get recorded. In terms of just my effectiveness at joke telling is all I'm saying. But we're going to do this again next week, and hopefully that time we're actually going to be able to record it properly. There is one thing I could potentially add to efforts, and that is using resveratrol. There's some good studies, and there's one study that showed it really reduced viral replication by increasing T cells in other coronavirus type infections. And so it's not going to hurt you to do this. It is a molecule that is found in grape skins, and in various types of medicinal plants will have high resveratrol amounts. You could probably drink wine, but it'd probably be quite a bit of wine, and so that might be immunologically weakening, is what I'm saying. So you can add 1,000 milligrams of that per day if you're in a high risk category. And homeopathic wise, there's a couple of extra homeopathics that have started to become clear for people who are infected. And again, I have not had the ability to, or the opportunity to really treat anybody with COVID-19, which is a huge bummer to me. But please don't get infected just to please me. And there's several remedies that potentially, if you've done the homeopathy introductions, you'll be familiar with all of these: sulfur, lycopodium, phosphorus, and bryonia, in addition to some of the remedies we previously discussed last time, including arsenicum and stibium. So not huge amounts of data coming out of there as well. Again, for the same reason as for the rest of it, we're really just don't have enough. We haven't had enough time and cases to treat. Okay, so open to questions. Does anybody have some questions that they would like to throw out there that maybe they didn't hear me talk about, or see if I can answer a question? I'm sure you're just reeling from what I just told you. I have a tendency sometimes to use big words. I apologize for that. And I hope you all are following me. I know immunology is not an easy topic, and it's not an easy thing to explain because it's not very black and white. This is one of the things that's actually shown up really interestingly, is that there has been incredible variance in how people are responding based on genetics, for sure, around the world. Actually, I was going to show you one really cool thing. Let me just share my screen here. I'm going to show you this one really cool thing first. I'm going to show you this cool website. I'm going to show you. This is, hopefully you can all see this. This is basically a video showing the spread of the genetic strains of the coronavirus around the world. I'm playing this a little fast, but in essence, it spreads out from Wuhan and Western Europe across to North America, and you can see Canada starting to contribute to the gene pool of that. And then this is, again, this is not case count. What this is actually showing the trace of where the virus came from based on genetics. Now, this is like a collection of data that's coming from around the world. I'll play it for you one more time here. So this is from an independent lab that's getting volunteer data of genetic analysis of the coronavirus in various locations, and map plotting that data as to how it spread. And so it's a fascinating graph to really show what ended up happening, because people had viral samples from all over the world. So cool, hey? Maybe you're not as excited about that as me. Yeah, and so, yeah, Melissa, the reason why it's probably showing up more in some places than others, there's lots of different reasons. I mean, some of it has just been what has been the orientation in that location, how have they responded. Some is definitely going to be the genetic background of those people. Some of them might be that there's different socioeconomic circumstances. One of the premises behind why there's disparity in between ethnicities is based on socioeconomic circumstances leading to increased disease rates, like cardiovascular disease in certain populations. And so there's a huge amount of variance. And, you know, we've seen in Iceland, they tried to do isolation procedures and their cases exploded there. Again, not particularly sure why. We did mention vitamin D last time, Maureen. It definitely has probably some bearing, but COVID specific, not necessarily, but definitely immune specific. Also, mostly because, in essence, it's one of those things that will improve immune function generally. The herbal preparations, we talked about, Shireen, in coronavirus 1, we talked about using elderberry in particular. And there's a handful of other things we just talked about. Again, we're limited. And then quercetin, glutathione, we talked in great detail the first time, because that quercetin and NAC, which is the precursor to glutathione, are my top two, and I totally stick by that still. So if you want to go back and take another look at the doses and things, we definitely found that in the United States in bioacoustics. If you've ever had bioacoustics with me, that is an approach that we often use for stealth infections and difficult infections. And so quercetin and glutathione were spikes under stress. So very likely to have a good impact. And do I think deaths will increase as we start phase 1? I don't think I think deaths will probably stay at around the same rate as they are now. We might see case increases. And, you know, again, we have this difficulty right now that we don't totally, like, we anticipated way more cases than we actually have. I don't know if you've noticed that or not, but there were projections that were done, and we're way underneath those projections for deaths and for total caseload. So that's a good thing. And I don't think necessarily deaths will increase. I think people will, just generally speaking, get better at doing some of the treatments, or lack thereof of treatments, or just management, not knowing what not to do. Sometimes it's just as important as knowing what to do. So hard to tell. I think there will definitely be some case bumps, but I'm not sure. Okay, so I lost my slides here. Let me just see if I can do that, because I had a cute slide to show you. There we go. So I thought this was a cool cartoon to stop on. I've definitely got to stop touching my face. Will isolation's not stop this? It's not going to stop at 100%. No, but because there's people out there that have to work in essential roles. And so, yeah, you can't stop it overnight. And the reality is you can't stop a virus. I mean, viruses have existed way before human beings ever existed. The reality is they're absolutely adapted to survive. And chances are good we're going to see waves of this. Some of the predictions have been that we're going to see something like a coronavirus, like it always does, surging seasonally. Are we going to see this version of it surging seasonally? Nobody has any idea, but there has been some talk of that. So we don't actually know. So thanks for coming. Love you all. Totally miss you. I'm just waiting for masks so I can actually see people in office any day now. So take care of yourselves, or like I said, page me for heaven's sakes, because I'm really getting bored. But only if you have an emergency, because it does wake me up out of a dead sleep, even during the day. All right, guys. We'll talk to you soon, and make sure you have a chance to go and take a look at Coronavirus 1 if you didn't see it the first time. That is definitely on the recordings pages on whole-life-medicine.com.